Hello and welcome to my lessons channel. I'm Sriram Jakate. I'm a gastrointestinal and liver pathologist, and these are educational videos. They discuss a specific topic, mainly the clinicopathological correlative aspect of it. They're not meant for treatment guidance. Let's get started. This lesson is about long-term complications of celiac disease and other diseases that you may see along with the lymphocytic duodenitis that you often see with celiac disease. Well, last week I made a video on how to confidently diagnose celiac disease on the initial duodenal biopsies. And please watch it if you wish. But the pillars of diagnosis are having some form of duodenal inflammation in the proximal duodenum with or without villus atrophic changes. And you can watch that video to get the details of that. And because it's an autoimmune disease, you need the antibodies to confirm that this is celiac disease, and that is predicated on two factors. One is having normal IgA levels, because most of the diagnostic antibodies that you see in celiac disease are IgA. You can do with IgG antibodies, but they are not as sensitive or specific. And you need continued gluten exposure to demonstrate both the antibody levels as well as the duodenitis. As soon as patient is on gluten-free diet, these things revert back towards normal. So you will have less antibody titers, less lymphocytic duodenitis if there is gluten-free diet or gluten restriction in the diet. And only a subset of population, about 30 to 40% of people, are even susceptible because of their genetic makeup. They need the HLA haplotypes DQ2 or DQ8, and only about 30 to 40% of population have that. The others are excluded from the diagnosis. And symptoms are not dependable. The classical gastrointestinal symptoms of diarrhea, malabsorption are only present in a smaller percentage of people, about 25%. The others have non-classical symptoms, or sometimes they're asymptomatic. In this lesson, we are going to talk about other diseases that may be associated with celiac. Now, these can be found either concurrently with celiac. They may be sometimes be independent of celiac, or they may be found first and then the patient is investigated and sometimes found to have celiac disease. And the other topic we'll discuss is what are the long-term complications of celiac disease. Well, the commonest association of celiac is with other autoimmune diseases, since it is a systemic autoimmune disease itself. Now, the estimated burden of other autoimmune diseases is about 15% in patients with celiac disease. And the greatest risk is patients who have family history of autoimmune diseases, and also where the celiac disease starts early in life, because they have longest period of exposure and possibility of developing other autoimmune diseases. Now, there is a very special relationship between celiac disease and Dermatitis Herpetiformis, and we'll discuss that. The best way to describe the association of celiac disease and Dermatitis Herpetiformis is that Dermatitis Herpetiformis is a cutaneous version of celiac disease. It shares exactly the same genetic susceptibility. It has a very similar autoimmune serology. It will show the same Marsh 2 or 3 type lymphocytic duodenitis in about 75% of the patients. Interestingly, the GI symptoms are there only in 10% of patients. So most of these people who are showing the lymphocytic duodenitis will not show any GI symptoms. What that means is the lymphocytic duodenitis is just a reflection of interaction of gluten in a susceptible individual, and it's not necessarily indicative of how severe the symptoms for gastrointestinal diseases are. And it also responds to gluten-free diet, just like celiac disease. And the diagnostic method is a granular IgA deposits in the skin done by immunofluorescence. This is a picture from Gluten-Free Society that shows the Dermatitis Herpetiformis, and it is sometimes described as a celiac rash. Dermatitis herpetiformis shows a characteristic bilateral rash, um, typically over the knees and the elbows. And this is a very familiar type of rash and location and bilaterality that is very familiar to dermatologists, may not be as familiar to primary care physicians. And as soon as they see this kind of rash, they order a celiac disease testing. And 100% of dermatitis herpetiformis patients have celiac disease by definition because of the serology and genetic susceptibility and even lymphocytic duodenitis. But 90% of them don't have any GI symptoms. When you look at the flip side, 10 to 20% of celiac patients also tend to have such kind of rash. So there is some overlap when you do have the GI symptoms with the celiac patients, and they can have dermatitis herpetiformis as well. So we know about celiac disease and lymphocytic duodenitis, but celiac disease may be linked with other lymphocytic disorders of the GI tract and also collagenous disorders, and that's an interesting association. Let's look at these associations of celiac disease with lymphocytic disorders of other parts of the GI tract. So first, the lymphocytic gastritis. Here you see a gastric antral biopsy with obviously increased lamina propria chronic inflammatory cells, but in the epithelium you have increased levels of lymphocytes, and this is described as lymphocytic gastritis. Sometimes it's associated with H. pylori or past H. pylori infection, but sometimes it's just an incidental finding. But in about 10 to 30% of the patients, there may be celiac disease along with lymphocytic gastritis. The other disease is lymphocytic ileitis, and often patients who have chronic diarrhea get random colonic biopsies and also ileal biopsies. In this ileal biopsy, you see that there is increase in cellularity in the lamina propria, so a chronic ileitis. And then in the epithelium, you have increase in lymphocytes, and this is lymphocytic ileitis. Now, this has a very high association with celiac disease because, after all, celiac disease is lymphocytic enteritis, primarily duodenitis, but it may also extend into jejunum and ileum. And when there is lymphocytic ileitis, you may also have B12 deficiency sometimes because of the main absorptive site of B12 in the ileum. The other association is with lymphocytic colitis. So here, microscopic colitis or lymphocytic colitis is where the crypts are distributed evenly, but there is increase in intraepithelial lymphocytes along with increase in chronic inflammatory cells in the lamina propria. This may even be associated with collagenous colitis. In this particular picture, it is not, but sometimes you have a combination of lymphocytic colitis and collagenous colitis. But when you have lymphocytic colitis, in about 5 to 25% of patients, you may have concurrent celiac disease with the celiac serology and lymphocytic duodenitis. Sometimes you see increase in lymphocytes in the esophageal squamous epithelium, and this is described as lymphocytic esophagitis. And you see this in autoimmune diseases sometimes, but interestingly, there is no established association of lymphocytic esophagitis with celiac disease. So it seems like celiac disease, lymphocytic inflammation is kind of limited to glandular mucosa, not squamous epithelium. So let's look at the association between celiac disease and collagenous diseases. So the first one is collagenous gastritis. This may be just an incidental finding or isolated gastritis where you have the chronic gastritis in the lamina propria with increased chronic inflammatory cells, but impressively thickened collagen band under the surface. And about 10 to 30% of such patients may have concurrent lymphocytic duodenitis and celiac serology, so they may have celiac disease, and it's worth investigating patients for that. The other is duodenum itself, along with the lymphocytic duodenitis, may also have thickened collagen band, and this is sometimes described as a collagenous sprue. And these patients tend to have refractory celiac disease with resistance to gluten-free diet for symptoms. And this is seen in about 50% of the patients have celiac disease along with the collagenous thickening in the duodenum. And then collagenous colitis, about 5 to 25% of patients may have concurrent celiac disease. In appropriate clinical setting, it's worth investigating if the patients do have celiac disease in addition to collagenous colitis. Now, these are some long-term complications of celiac disease. The first and foremost is celiac disease stays undiagnosed, so there is no treatment because nobody knows that the patient has celiac disease, and this happens to 75 to 80% of the patients worldwide, mainly because they don't have the classical symptoms that can lead the medical care team towards celiac disease diagnosis. The other long-term complication is refractory celiac disease, and we'll discuss this in greater detail. Along with refractory celiac disease, there may be ulcerative jejunoileitis and sometimes development of lymphoma along with refractory celiac disease. And this is described as EATL or enteropathy associated T-cell lymphoma. This is almost exclusively seen in celiac patients in the small bowel. And finally, because of the chronic inflammation in the duodenum, there may be a risk of small bowel adenocarcinoma. This risk is lower than that for lymphoma, but there is an increased risk nevertheless. Now, for a pathologist, sometimes there is an important question posed by the gastroenterologist that there is a patient who has celiac disease but is not responding to gluten-free diet. So this is refractory celiac disease. It is rare. It affects about 1 to 4% of patients with celiac disease, and it tends to occur in older patients with long interval of time between symptoms and the correct diagnosis of celiac. In other words, there is a protracted, relentless exposure to gluten, and that may result in refractoriness. So there are two types of refractory celiac disease. One is RCD type 1, which is benign and it's reactive. It's seen in about 85% of patients. Here, there is refractoriness to gluten-free diet, but this is a polyclonal or oligoclonal reaction. It's gluten-independent disimmune reaction. And it's important to demonstrate the polyclonality in this case. Here, the T cells that are there in the intraepithelial lymphocytes, they have a surface CD3 positivity and CD8 positivity. Now, the other type, which is rarer, is seen in only 15% of patients, is the RCD2 type, which is actually a neoplasm. It's in situ enteropathy associated T cell lymphoma. The other way of describing that is RCD2 or refractory celiac disease type 2. Here, it's a clonal type of T cell reaction where the surface CD3 positivity is lost and there is now a cytoplasmic CD3 positivity, and the CD8 is positivity is lost. But you may have to take the help of hematopathologists to make these judgments about clonality. So for RCD type 1, which is a reactive condition, versus RCD type 2, which is a neoplastic condition, you can do the simple immunostains of CD3 positivity on the surface and then cytoplasmic CD3 positivity in RCD2 and then CD8 in RCD1 and lost CD8 in RCD2. But it's best to take the help of the hematopathology team and find out if you can do flow cytometry studies or TCR studies to demonstrate the clonality part of it. Because once you have a RCD type 2, there is a potential for ulcerative jejunoileitis, and for that there may be need to do capsule endoscopy to go further down into the jejunum to see if there is ulcerative jejunoileitis, and also to be mindful of developing enteropathy associated T cell lymphoma. So multidisciplinary team may need to get involved, a gastroenterologist who is very familiar with these advanced conditions in refractory celiac disease, and a dietitian who ensures that there is no continued exposure of gluten, and the heme team for developing lymphoma in RCD type 2. So while refractory celiac disease type 2 is quite uncommon and seen in less than 1% of celiac disease patients, when it occurs, there is a risk of ulcerative jejunoileitis. And here is a segment of small bowel showing multiple ulcerations that are not very shallow. And here is the histology of these ulcerations. You have ulcerated surface with granulation tissue and adjacent lymphocytic jejunoitis linked to celiac disease. And this is seen exclusively with patients with RCD type 2, which is a clonal form of refractory celiac disease. Enteropathy associated T cell lymphoma is a special type of lymphoma that is almost exclusively seen in celiac disease. And the lifetime risk of this in celiac patients is about 7%, but the risk is really mainly seen in patients who have refractory celiac disease type 2 and who may have ulcerative jejunoileitis associated with it. So here is a segment of small bowel showing the lymphoma infiltrate that looks like a firm mass that is a rubbery gray-white firm mass on cut surface. And histologically, you will see very atypical appearing lymphoid cells infiltrate in the tissue. Another tumor that may occur as a complication of long-term celiac disease is a small bowel adenocarcinoma. Although the risk is stated to be 10-fold higher than average, the overall risk is quite low because small bowel is not a common site for adenocarcinoma for multiple reasons. And actually, the risk for lymphoma in celiac may be greater than adenocarcinoma. And when the adenocarcinoma does occur, it's usually in the areas where there's maximum chronic inflammation. So here is duodenum showing, stricture with adenocarcinoma. So let's summarize this. Celiac is an autoimmune disease and may be associated with other autoimmune diseases and also lymphocytic diseases and collagenous diseases of the GI tract. Dermatitis herpetiformis is a cutaneous version of celiac. Everything is like celiac disease, except the GI symptoms are seen in only 10% of patients. Refractory celiac disease is a rare complication seen only in 1 to 4% of celiac patients and may generally have a benign phenotype, and that's more common. It's called RCD type 1. Rarely there is a clonal or a neoplastic phenotype, and it's called RCD type 2. Now, RCD type 2 is a precursor and indicator of ulcerative jejunoileitis and enteropathy associated T-cell lymphoma. Small bowel adenocarcinoma is quite rare, but it's a complication described in celiac disease. Hopefully, this is a good summary of all the associated conditions that you may see with celiac and also some of the long-term complications. Hope this is helpful.